accomplishing all of the things that we have identified we wanted to do for our community, what would that look like? What would success look like 5 or 10 years down the road? And one is to be the highest performing, most clinically sophisticated critical access hospital in the country. And while as compared to other hospitals in the state, we're considered a small hospital, we are actually the largest critical access hospital in the state as defined by total revenue. And the reason we are is because we are in a community, a fairly large community for a rural community of active and engaged residents who would prefer that their care be delivered locally. So we have a far more comprehensive array of services than most critical access hospitals. And we do that because if we bring in the right providers and do a good job providing the services, our community chooses to use them here. So this is something that we're going to continue to grow. Next is to be a fully accredited, award-winning organization. There are all sorts of accreditation bodies in the healthcare space, and we look for the ones that make us better. For instance, there's an accreditation body that works with our regulators and accredits hospital to make sure that our policies and procedures are correct. The way we are delivering care is of the highest quality, and the way we are documenting that care is of the highest and most appropriate quality. We look for these accreditation bodies because, again, it makes us better. And secondly, if we are being accredited by the same accreditation organizations as Virginia Mason, Swedish, Providence, St. Michael's, Overlake, Evergreen, all of the other hospitals on the Puget Sound corridor, well, then we feel we've earned the right to say to our community that for the care that we provide it with the same diligence and focus on quality as any other organization in the community. We felt that if we weren't seeking those accreditations, we wouldn't have the ground to stand on to say that. And secondly, by virtue of doing this work well, we are frequently, our progress and our success is frequently noted by organizations that rank or evaluate the success of different hospitals. And we think speaking to the community about our success in these areas is a great visible marker of our progress. Next, holding the trust and loyalty of our patients and community is a big deal. We concluded years ago that we're in the trust business, that making decisions regarding your healthcare are driven by many things, but most importantly, they're driven by, do you trust the provider that's taking care of you? Do you trust the team around the provider? Do you trust the organization that provides the care environment for the provider to do the very best job that they can for you? So we are really focused on maintaining that trust, because it will drive growth, and driving growth will allow us to stay strong and independent. And lastly, hospitals are nothing but fancy buildings with expensive technology if we don't have a great employee base. So we are very focused on recruiting and bringing in the right people for our team. And then once they are here, working really hard to provide a work environment that is satisfying both personally and professionally, and allows our providers to grow and develop. And frankly, that at any time in the 30 or so years I've been doing this has been a challenge that has been an extraordinarily challenge the last 2.5 years. But it remains our most important goal. Next slide, please. Our mission statement, again, it's about holding trust and improving the health of our community. This is something that's our North Star in terms of our work. Next slide, please. Our vision statement, what the organization, you know, aspires to be when it grows up. We want to be the first choice for quality of healthcare in our community. We want fewer people to leave Port Townsend in seeking their care. So we'll do that by delivering safe, high quality care, championing an engaged workforce, inspiring professional excellence and personal commitment, providing leadership to improve the health, wellness, and vitality of our community. For a small rural hospital, we are way outside of the hospital footprint and getting involved in food insecurity issues, the housing insecurity issues, all sorts of population health initiatives that have more to do with keeping our community well than taking care of them when they're sick. And that's where we think we need to be. And then lastly, demonstrating fiscal stewardship and thoughtful decision making to make this all work. And I could spend an hour on this topic alone, but the sole reason that we are fixated on remaining financially strong is because it allows us to maintain our operating and governance autonomy. And if you look around, that is becoming a greater challenge for small rural hospitals. But there is no question in the board's mind that this hospital will stay as an independent hospital. And that the trade-off to that is, well, we're going to have to find a way to have a strong financial base. So big part of our focus today and tomorrow is that. Next slide, please. Our values. I'm sure these values look like the values that hang in the hallways of you know, every business and certainly every hospital in the country. The question is, can you claim them for your own? And we view this as a work in progress. That we feel that these values represent who we are and how we relate to each other and to our patients, but we also feel that we can always make them greater and more integral to every interaction a Jefferson Healthcare employee has. But they too are our guiding light. Next slide, please. So Jefferson Healthcare is a critical access hospital, which means we are limited for 25, just to have 25 beds. Now, during the public health emergency that was declared by the governor and the president, that cap is lifted, and there were times where we bumped right up against that 25 beds census level in trying to take care of the crazy needs of the last year. We are governed by a 5-member publicly elected board of commissioners. Many of you know that. Lots of people don't. Lots of people don't understand what a public hospital district is because they're new to the community and come from a community that doesn't have this model, or a state that doesn't have this model. But Jefferson Healthcare is a public entity. We own and operate 6 rural health clinics, 5 primary care, and an express clinic. And included in one of those primary care clinics is a dental clinic, 9 specialty service clinics, and employ around 84 primary and specialty care providers. We also own and operate the home health and hospice service in the community. And we're the largest employer in Jefferson County, public or private. Employing, and this is a couple of months old. The numbers in both of these areas have climbed. But has the total payroll number, but basically a number that you can probably wrap your head around, more than 65 million, is every day we dump $178,000 of payroll into our community. So in addition to being the healthcare system of East Jefferson County, we're a pretty big part of the economic engine of Jefferson County, and that's something that we feel is helpful to the vitality of our community as well. Next slide. In the last 8 years, Jefferson County's population has grown by 5%, and we've doubled our adjusted patient days. And that is because care that either wasn't being sought for lack of access, or care that was being sought outside of our community is now being sought here. And that is a crazy high growth number that we could not have imagined when we were planning the ESSB building, the building that we completed in 2016. I mentioned how many FTEs we've had, but that number has almost doubled as well. And number of employed providers tripled in that time. And another number that's hard to wrap your head around, 625, we touch 625 patients per day. That's not phone calls. Those are folks coming into the emergency department, coming in for a lab test, coming in for an ultrasound, CT, MRI, or a primary care visit, which, based on the size of our community, that just astounds me, that number, and I guess indicates the importance of healthcare in our community. Next slide, please. We are the oldest county in the state. 1/3 of our residents are 65 and older. And depending on the data source you look at, I've seen we are either 7th or 9th oldest county in the country. So this has an implication on healthcare. Folks in that demographic tend to use more healthcare than folks in the below 30 age demographic, and a different type of healthcare. And we need to be very mindful of the services that we offer and how much of it we offer in order to meet that need. And then lastly, we're the predominant provider of primary specialty surgical care, urgent, emergency, hospice, home health, and over the last 2 years, all things related to COVID in the community. And that has never felt more apparent than the last 2 years, where when there was a need to set up a COVID clinic, or set up a COVID hotline, or set up a testing drive-through testing center, or set up a place to stick 29,000 needles in an arm. We looked around the community, and while there were agencies that stepped up and wanted to support and did a great job helping us just by virtue of who we are and what we do, we were really the only organization with the scale and the girth to respond to that. And that was and continues to be a heavy burden, frankly. But on the other hand, it was one that we all felt very good about delivering. Next slide. So this is just a bunch the numerical side of all of that growth, comparing 2011 on the left to 2021 annualized, and I think those aren't the actual numbers. They're pretty darn close. But you could see our operating revenues more than doubled, as well as operating expense. Net income has bounced all around the last 2 years. The net income basically is the amount of revenue left over after you pay all the bills. And the last 2 years have been kind of tight with respect of maintaining a strong financial base. However, it's because of the unique challenges of COVID. We've managed to maintain and even grow a little bit our cash reserves. FTEs, payroll is like $70 million. I'm going to have to update that slide, aren't I? And then just a bunch of other services that we monitor that have sort of been on the growth train and seeing more patients locally. So the real satisfaction in seeing these numbers grow is it's one less disrupted day for a member of our community driving to Silverdale or Seattle or Sequim to seek care. And that's really what I think our community most wants from us. Next slide, please. This is an assessment of public hospital districts a taxing situation. As a public hospital district, we have the ability to tax to offset our operating expenses and to tax for constructing new buildings. And these are all of the local public hospital districts with their total operating expenses and their tax revenue, and then the tax as a percentage of their operating expenses. And the reason that I show this slide is that we have a extraordinarily low tax basis for a hospital our size. That up until now, it has been important to us to not have to think about having a tax base similar to other local hospitals in order to operate. We felt if our business model could keep our rates low, keep our quality high, and allow us to invest in new technology in buildings, terrific. That should be the challenge, and we've delivered on that challenge. The degree of project that we are looking at going forward might allow us, or is likely going to require that we revisit this. And just to give you some perspective, would be similar size hospital, a little smaller, $5.7 million of taxes. Jefferson Healthcare on the bottom of the list, $500,000 of taxes. So basically a $5 million head start at the beginning of the month in order to meet community needs. And then they do a good job of that. It just is, I think it's at a point where this is something that we're going to have to revisit. And going down the list, you can see the tax revenues of many of the local hospitals. Next slide, please. This is a slide that, 20 years ago, there was a lot of talk about hospital consolidation, but frankly, not a lot of it actually happening. It was like a industry of consultants that would bounce from one hospital to another and put plans together on what a merger would look like, but they very seldom occurred. Well, until about 5 to 10 years ago, and then they started happening a lot. Now, the upside to a merger is that it typically provides you be part of a larger system, a lot of specialty expertise to help you deliver better care and access to deeper pockets to recapitalize your campus. Possible downside is that 100% of the operating autonomy is no longer in the community that the hospital supports. Again, I had mentioned the board looks at that equation in a very one-sided way, maybe recognizing some of the upside and how that would be a good fit for some organizations and communities, but having no interest in Jefferson Healthcare going down that path. We remain very focused on the corporate office of Jefferson Healthcare being located in the same community it serves. Next slide, please. And then our 2022 challenges. I made this slide about a year ago, right before Delta ran us over and before Omicron. So it's amazing that I was thinking at that point it had been a tough go, and it's not over. Well, I think with what's going on in our community today, I will tell you it still remains a tough go, and it's still not over. It's a much more manageable situation now, but it's a far cry from being in our rearview mirror. And the healthcare community is very aware of that. We also want to encourage and recognize and be a part of collaborative solutions to other complex and worsening community shortages. Housing, childcare, the overall labor pool across the board, community wellness and aquatic center. We think that's a big need in our community. We want to be part of that discussion. And then just overall economic development that brings family wage jobs in to support the family orientation of Port Townsend. And then to address the facility issues and additional space needs of the 65 building and the 88 building and the new building, which may not mean much to you until I get to the next couple of slides. So next slide, Britt. Okay, so that's who we are and what we've been up to the last 10 years. And there, while we have very serious challenges moving forward, they're for the right reason. When we built the ESSB, you know, we had some concern about, boy, you know what, if we're wildly successful and truly curb outright out migration of people seeking services, we're going to wish we had built that larger. And that's kind of what happened. So the discussion I'm stepping into now is dealing with a building that probably needs to be addressed, and how we add new space to accommodate new services. So next slide, please, Britt. So when we made application for and went through the design process of the 2016 building, the new building with the main lobby and the fireplace that you check in at, we had to bring in a consulting firm, an engineering firm, to do a tier 2 seismic and structural evaluation. A tier 1 evaluation basically is a paper exercise where they look at the plans of the building, original plans of you know, in the early 60s and late and mid 80s, and determine if the structural integrity that was required by code and it was built to by plan meets code today, and also is, you know, is considered safe in the event that the ground starts to shake. And so the tier 1 report was insightful, but not as daunting as the tier 2 report. The tier 2 report is engineers actually come on site, they poke holes in walls where they can, and they look to confirm how things actually were built, or they chase down as-built and look at changes. And the tier 2 seismic and structural evaluation report was pretty daunting. It indicated some fundamental stability issues that pertain to the connections between the walls and the foundation, and the walls and the roof. So those seem to me to be two pretty important connection points, that don't matter a whole lot if the ground isn't shaking, but matter a great deal once that does occur. And in addition to that, the walls are too narrow for the height of the structure, sort of an engineering deficiency that we probably just learned over the last 55-ish years, more so than building improperly. Next slide. So to use the language in the agreement, at design level event, in other words, at a seismic event that the building in 1965 was constructed to withstand, the discrepancies may lead to possible partial total collapse of the masonry shear wall. The masonry shear walls directly support the roof of the structure and elevates the risk, as any collapse of any masonry walls could directly result in collapse of the roof areas of the building. Well, that has my attention for two reasons. One, I'm the CEO, and I know this, and it's pretty daunting. Secondly, I'm in one of those buildings where the masonry walls directly support the roof structure inadequately, and the risk is elevated if the ground starts to shake. So the engineering firm recommended that a building replacement occur within a 7 to 10 year window, and the date on the report was 2014. So when we started our master site planning work in 2010, we were doing that thinking that we were going to address this within that window. In addition, when we were going through all of the regulatory sign-offs in 2014, maybe, as we were getting approval to build the building, we showed this report and made the commitment that recognized what it said, and made the commitment to the Department of Health, and others that we will follow this recommendation because we need to. So that's an important part of this too. Next slide, please. So what is the 65 building? We talk about it like, everybody knows it. It's like, we talk about it like it's Aaron Stark's cafeteria, that everybody in the community knows exactly where it's at. Well, interesting, Aaron Stark's cafeteria is included in the 65 building, but it's the building enclosed in the red circle, and basically right in the middle of campus. So if the seismic event were to occur, lots of bad things would happen. But what we would have to be forced to contend with is a significant disruption to critical services in the hospital, and more importantly, critical throughput in the hospital. It's a lot of traffic that goes from the main lobby to diagnostic imaging and to the laboratory and to the surgery area. That would be completely disrupted if this part of the campus was disabled. So lots of reasons to address this. Next slide, please. And this is another slide that pretty much captures the different portions of the campus and when they were built. Next slide, please. So what's in the 65 building? The OBGYN clinic, the express clinic, the MRI, the kitchen and cafeteria, and hospitals can't operate without kitchen cafeteria, dietary nutritional consultation, pre-op, vascular imaging, environmental services, facilities, biomed, and some degree of laboratory and imaging, although most of those are in the 88 building. Administration is all in the 65 building too. The go forward plan for us, however, is not in new space. It's across the street in 915 Sheridan, where we have primary care offices on the bottom floor, and on the top floor, administrative offices. And that will be administration's new home, both when we do the replacement project and just going forward. So our plan is to demolish, replace the entire 65 building, and create new space for those hospital clinical services or hospital-based services, not administrative services, and to retrofit the remaining 1988 brace frames located outside of the ESSB improvement space. So the second part of the Tier 2 recommendation was that the issues in the 88 building weren't as daunting as the 65, built 33 years later, 23 years later, and so that they could be cost effectively addressed with support frames. So those are the two problems that need to be solved. Next slide, please. We also have a crazy need for more space. We literally are retrofitting broom closets for clinical support space in some of the clinics upstairs. That at the time we thought we were overbuilding, and we didn't. So we need more space for medical oncology. We need more space for dermatology, wound. The Express Clinic needs about twice as many exam rooms as it currently has. And the Obstetrics and Gynecology Clinic, not only are they located in the 65 building, but they have inadequate space for 3 excellent providers and all of their support team. So those are existing services that we need more space to continue operating. We also want to develop space for new specialty services. Part of the master site plan that we completed, late last year, we worked with a healthcare services utilization projection consultant to try to look at the demographics of our community, the projected use of services that demographic would usually see. And then we actually pulled out from our Epic system the number of referrals for services that we don't provide that were being sent out of our community. So we were able to identify the highest services of highest out migration numbers, which indicate to us the community has a need for. And those are ear, nose, and throat, neurology, and pulmonology. And we have also been talking about and included in this year's strategic plan, developing a geriatrics consulting practice. And what that would be, it would be set up similarly to the psychiatry and psychiatric ARNP practice that we have in our rural health clinics, where the providers carry a panel of patients, and they work in a consultative role with all the other primary care providers as they take care of patients, get through, bouts of depression or other behavioral health issues. We would see the geriatric service being similar, because in this community, where 1 in 3 members of your population are 65 and older, there's probably not enough geriatric physicians available to meet that entire panel need. And plus, all of our providers have a significant 65 and older patient population. So our thinking is that these geriatric providers, if we were to move forward with this, would serve a consultative role to speak with primary care doctors and internists taking care of elderly patients. Hey, I'm trying to decide between these two drugs, which, from a perspective of a geriatric provider, do you have a recommendation on what would work best? And secondly, just they would carry a panel for patients with very complex geriatric driven needs. And we are already bumping up against available space needs in our surgery center, and since most of our surgeries are outpatient or ambulatory, we believe that standing up 2 or 3 ambulatory surgery centers would not only provide a better outpatient surgery experience immediately for our patients and our providers, but it's the growth plan. And we think by setting them up in this environment would be more cost effective than trying to attach them to the existing surgery area. And lastly, another area of significantly growing patient outmigration or patients leaving our community for care is seeking radiation oncology. For those of you who have had a cancer diagnosis or who have helped a friend or a loved one through a cancer diagnosis and treatment, frequently there are 2 forms of therapy or treatments prescribed. One is medical oncology, which we provide here with excellent providers and an excellent care team, and we feel very good about it. But often, in addition to medical oncology, radiation oncology will also be prescribed in kind of the same or a 2-follow regimen. And those patients from Port Townsend have to drive to Sequim or Poseball or Silverdale or Seattle several times a week for several weeks to go through that regimen. And if it's done on or around the same time as the medical oncology, it is just not a pleasant experience, and we feel at times it prevents patients from seeking that care. So our medical oncology team is very interested in bringing a comprehensive approach to cancer care into our community. Next slide. Planning process and timeline. Next slide. I will go over this quickly. 2020 to second quarter of 2021, our 10-year master site plan, which basically every service that we could think to provide or think we will need over the next 10 years what would that look like? And frankly, you may have seen a project and a number in the press, and that's where this number came from. That if we were to build out 10 years of needs, a high level cost estimate of what that would be. That's not our intention. 2021 determine a project approach. We made application to go a progressive design build approach, the first public hospital district in the state to be awarded this the right to take care of our parents first, or build our building this way. There you go. Thank you. We went through this extensive process that I will speak to on my next slide to assemble the team. It's a process that is required through the state auditor's office to make sure that when we give a significant contractor's contract, we do it in a fair and an open and transparent way. And we went through this request for qualifications, request for proposals, scoring process, and identified Abbott Contractor out of Seattle and ZGF Architects out of Portland and Seattle, and OAC is our project management team. Second quarter of the year, we reviewed the master site plan, validated our priorities, and are beginning to seek community feedback. Next quarter, finalize design, establish cost estimates, and determine funding sources. If we determine a bond is necessary, and we think it will be, the fourth quarter of 2022 or this November is when that would occur. And then first quarter or second quarter of 2023 is when the project would begin. Next slide. This was at the first presentation, someone asked, so how'd you pick your contractor and design team, which was a very fair question. And it was a extraordinarily complicated process that is state regulated to make sure we give everybody, all eligible contractors and design teams a chance to perform this work. So we went through this request for qualifications, request for proposals, a bunch of meetings and scorecards to come up with the winner, Abbott and ZGF, and we couldn't be more happy with them, and finalized that in January. Next slide. And then possible funding sources. Next slide, Ben. There's 1, 2, 3, 4, 5 funding sources for anything that we do here. The first is Jefferson Healthcare cash reserves. We would peel off as much of reserves that we have that would be responsible and allocate to this project. The Jefferson Healthcare Foundation contribution, we will look toward to offset the cost of this. Jefferson Healthcare debt capacity, we built the, $28 million ESSB based on our cash reserves and in effect going and getting a mortgage, committing to being able to operate the services within that new beautiful building in a way that threw off enough revenue in order to pay a pretty hefty mortgage over 28 years. But that's how a lot of organizations pay for their facilities, and we would expect that would be included in this project. And then state and federal grant and appropriations. We've been in touch with our legislative delegation about state appropriations. We've been in touch with our congressional delegation as recently as 2 weeks ago, and have a $2.5 million appropriation request submitted into our offices of our congressman to offset the cost of a linear accelerator. So we are looking for federal offsets too, to keep the cost of this project as low as possible. And then a bond measure, depending on what we ultimately decide that we have to build, the services that go in that, and how much it costs. The difference between the first four categories will need to be made up by a bond measure. And the only thing I can say for certain right now about the bond measure is that we're not going to ask the community for $100 million. That would just be a dumb thing to do, regardless of the needs that we identify. And we are sensitive to the world we live in, and we are sensitive and supportive of the other needs of our community. Healthcare is important for a vital community, but so are new schools, and so are high quality mass transit systems, and so are city buildings and community centers. This all has to, whatever we decide, the board is committed to doing this in the context of go forward with our community and making sure that how we are responding to the problems we're trying to solve is done in a responsible way. Next slide. All right. As conversation starters, I have 4 questions loaded. Next slide, Britt. But really, this is an opportunity for all of any of you out there that have a question about the problem we're trying to solve and our approach to ask it, or a question or comment about the services that you would like us to consider bringing into the community. So just as a fire starter, we've identified addressing the seismic vulnerability and structural issues of the 65 and 88 buildings as our highest priority. So my first question is, does that seem like a reasonable thing? Is that where our first construction dollars should be aimed?
Hi, Mike. This is Case, one of the board members, and just to get the ball rolling from other people speaking, I want to say that clearly number 1 is something that the board is very set on doing, because in fact we have no choice.
All right. We have focused on understanding additional community healthcare needs and trying to deliver them over the last decade. That has been a big part of our our annual strategic plans. Should we continue to try to understand community need, and if we can provide those services in a high quality way, should we continue to add them, knowing that it will require more space and to some extent more clinical complexity and to some extent more cost? Right. I have to tell you that if there aren't any comments to these questions, I'm just going to write in the answers I want. And then I think I will move on to the next question.
Hey, Mike, there is a question in the chat box there.
Yeah, I'm gonna get
Okay.
to that. It's a nice segue to I think the third bullet, and that is the PT and rehab is located in the basement of the program, and they are not, although the project is, well, I have learned that until until you put the pencil down and pick up an ink pen, your planning is always fluid, but it's an area that is also challenged for space, and is not being considered to be part of this project. And I've attempted to answer this question on several occasions, primarily to physical therapy space or staff, like going, "Hey, have you forgotten about us?" And the answer to that is no. It's just that the hospital construction is really expensive. There are limited resources, and just like any remodel project, there are things you would like to do and frankly probably need to do, but you may not be able to get to this go round. And right now, that's where PT and rehab is. But they're in good company. There's a couple of other services that we know we're going to have to address and find a way to create more space to accommodate the very good work that they're doing down there. You're welcome. And keep asking, because I don't want you to think that we're clueless to your challenges down there. If money weren't an object, I promise you we would fix that now too. So any other questions or comments? What else do you think? Looks like there's a handful of leaders from the hospital on the call right now. What else should we know? We're trying to keep our ears close to the ground and understanding needs of the community, but we obviously don't know everything. It looks like there's a hand up. Is that Jeff Chapman?
Yes, yes, Mike. I'm Jeff Chapman, the county assessor, and of course, I'm really interested in the bond discussion. It gets to November, and we get really swamped in our office trying to get all the levies started up and process and all the budgets set. Is the idea with a bond that it would be run in November and then applied starting in 2023 taxes?
Yeah, well, the plan now, and everything is in play until it's not. But the plan now is to finish the design by summer, attach a cost to it, understand what our other funding sources are and look like, and then ask the board at the end of July to consider a ballot measure to be placed on the ballot in November. That's the plan now, Jeff.
Okay, thank you. And you probably don't even know it depends how much you're going to collect before you know what the first year collection will be. Well, are you thinking of 10 or 20 year bond, or is that still too early?
Yeah, it will at least be 20 years.
Okay, thank you.
Yep.
And Mike, if I could add to that, this is Case again. Thanks for your question, Jeff. I was just looking at my own property taxes and getting back to the comment that Mike had made earlier. When I look at my property taxes, 0.75% is the only thing that goes to the hospital district at this time. And so this sort of reinforces what you were saying earlier, Mike, that we do not rely much on the community at this point in terms of property taxes. And when I look at that, Jeff, I think that less than half of that is actually for a bond. Some of that is for a general tax levy that or I'm not sure if that's the right word, that we get. But really, we only have one bond that is outstanding, and so it amounts to about 1/4 of 1% of what I pay in my property taxes in order to have this very important institution in our community with all the benefits that Mike has explained. So as a board member, I'm obviously very supportive of this plan and yeah, so
All right.
I think it's important.
Thanks, Case. I will address Lissy Cora's ask in the chat box because this has been the challenge for every healthcare administrator in every hospital in every state of the country for the last 2 years. Maybe even the greatest challenge that of anything I've ever dealt with since I have been doing this is this confluence of this an incredible staffing shortage in healthcare, top to bottom. That frankly there's a lot of appropriate focus on bedside caregivers, but I can tell you that the last 2 years has been tough on everybody who has a Jefferson Healthcare badge on them. That coming to this place when there were all kinds of concerns and far more questions and answers about just what the hell it was we were dealing with. And also, the great resignation, great resignation of the issues. What do I want to do with my life and where do I want to do it? Issues that are occurring in every other industry are occurring in healthcare too. So there's that. Then there's this very serious and growing staff shortage that we've been watching occur for the last several years, where there just aren't enough healthcare workers being trained to replace the healthcare workers that are retiring. And then now that with the pandemic and all the issues associated with that, it's been really challenging the last couple of years. In addition to that, and Port Townsend is not isolated. The same issues are in Sequim and Port Angeles and Kitsap County. The housing prices and availability has just shot through the roof. So right, we are working really hard to drive down and fill positions, and we have 870 employees, and we have about 88, say round up to 90 open positions now for positions that are just temporary and per diem. So even if we're wildly optimistic and say we will replace 45 of those 90 open positions by local people living in Port Townsend, that means that in addition to finding 45 qualified healthcare workers to take the job, we got to find 45 homes for them to live in. So it's an issue that we can't help but solve, though, because by not continuing to provide the services that our community needs because of these other challenges, I don't think that's right either. It's just going to take economic development, county, city, all of the players, chamber, to some of the great affordable housing work that's being done with agencies in this community, but a concerted effort to not only do this to solve our problem, but John Morrill has the same challenge in recruiting new talented people to come to Port Townsend for the city. That now that there has to be housing for those folks too. So very important problem. We can't not solve it. And our thinking is it's like we're going to continue to move forward with what we think we need to do, and then sit at the table of some of this work around. And it's certainly affordable housing, but it's also community-based housing, which means housing inventory for the full spectrum of people that move to our community. And it's a daunting challenge, but it's one we have no choice than to take on and we'll be a part of. Are there any other questions? I saw some hands shoot up, but then they shot down. So I don't know if the question was answered or if you just got tired of listening to me, one or the other. Okay, well, it's 2:30. I will tell you that this presentation changed from the first time we gave it Monday because of input from folks who listened to it. You know, hey, you went a little too much on this and not enough on this. Can you address this for the community? So you would do me a favor if there's something about this presentation that was unclear or not in depth enough or something missing, if you let me know, because we truly are in the community of listening and understanding mode, and any help you can give us to truly understand where the community sits with this will be helpful, because it's a big deal. It's we thought the ESSB building project was a big dang deal when we built that. What we are proposing is replacing this old building and building an ESSB building at the same time, and we want to make sure we understand the sort of the interests and needs of the community before we start doing that. Okay, anything else for the good of the order? Case, got anything else? Okay.
Nope. Thank you very much, Mike.
All right. Thank you very, very much for your time. Appreciate it.